the audience already is logical. That's how we're going to be arguing later.
It's probably somebody watching the football.
So the audience is already sensible and logical, so what I have to do is be careful not to change their mind, which is, makes my tasks a little bit harder. I'd first of all like to thank the organizers for their kind invitation, and just introduce myself. I work in Limassol, I work in Pantheon Eye Center, and I'm one of 4 VR surgeons in a group of 14 surgeons altogether. Half of our work is government funded, and the other half is self-funded. So that's our clientele. Now, David and I, before this debate, exchanged a few friendly emails just to get a feel of what the atmosphere was going to be like. And I just want to show you his last email. He said, I'm going to bring modern evidence-based that you're wrong, but I'll try and be gentle with you. He's worried me a little bit. Okay, so I thought if he's going to use evidence, I have to do the same thing. Okay, so I did a literature search, and I put Glaswegian debate gentle, and I got 0 hits. Right? So I thought, well, I'll just put Glaswegian, and I got these 2 guys, neither of whom are gentle. So now I was really worried that I'm going to have to work for this to win this debate. So what do we do in our everyday practice when we get a retinal detachment? What influences what we do? Well, we want the best anatomical and visual outcome for our patients. We want to calm our patient and relieve their anxiety. We're influenced by the availability of theatre space and our theatre staff. We don't want to inconvenience our colleagues and take up theatre time and cancel other people's lists. We want to minimize the cost of treatment, and of course, we don't want to be sued. So what we do, we need to be able to justify. And there's a lot of evidence out there as to how we should behave. The first thing is who should be doing the operation. Okay? So the Cambridge group looked at this when they audited their retinal detachments, and they compared retinal detachment surgery success rates in district general hospitals compared to a dedicated vitreoretinal unit, and the vitreoretinal unit was significantly more successful. So they moved all their retinal detachments to their dedicated unit, and they're re-audited 5 years later, and they've proven that basically dedicated VR units get better results. So that's one of the major factors. They also looked at trainees, and they found that trainees, unsupervised trainees, did far worse than supervised trainees. So vitreoretinal surgeons should be doing the surgery, and trainees should be supervised. Right? The anatomical factor that made influence in this study was macular involvement. So if you let a retinal detachment involve the macula, you are less likely to be able to reattach it in one successful operation. So you need to operate before the macula gets detached. What else? Duration of detachment. If you look at the success rate of a single operation with duration of detachment, if you have more than 7 days of detachment, then you're less likely to get a primary success. And so is preoperative VA. Therefore, if your patient comes in with 6/6 vision, then you are more likely to have successful surgery if you operate before their vision drops. So you don't want to delay until the patient loses vision before you operate. Planned surgery does better than out-of-hours surgery. So there's no argument in most surgical specialties on that, and that's termed the weekend effect. And it's influenced by availability of equipment, availability of appropriately trained staff. So either way, macula-on or macula-off, we do better if we don't do it in the middle of the night and if we do it on one of our lists. So we have to make a decision which one we're going to do first. Okay? Now, what affects our final visual outcome? Certainly macular involvement. Nobody can argue that before the macula detaches, the patient will do better than after the macula detaches, and there's plenty of animal data to show that photoreceptors start to die as soon as the macula detaches, and there's also OCT data and clinical data showing that the the bigger the height of the macular detachment and the bigger the distance between your photoreceptors and your RPE, the more photoreceptor damage you're going to get. So what other predicting factors are there for good visual acuity? Preoperative VA. There's a host of studies that show that the better your visual acuity pre-op, the better your visual acuity post-op. Getting it right first time. So you want to be successful first time, and then you're more likely to get better vision. But we already know that your macula needs to be attached to increase your chance of having a successful surgery. And the number of quadrants involved, it makes sense that if all of your retina is detached, then you're going to have worse vision post-operatively. Timing of surgery in macula-off detachment. So we don't disagree here with David. Okay? If you operate within 1 week or within 24 hours and your macula is already off, there is little evidence that it makes any difference. Now, the Williamson study that he showed us did find slight difference between 1 and 3 days and 4 and 6 days. But only this study showed that. Every other study that looked timing of surgery in macula-off detachments, they found no significant difference in final visual acuity if you operated within 7 days. What about macula-on retinal detachments? It is no coincidence that nobody has taken a group of macula-on retinal detachments and sat on them and waited to see what happens to them if you leave them 1 week, 2 weeks, 3 weeks, and do the prospective study. They'd go to jail if they did. They'd never get ethical committee approval to do that. But people have looked at this. Okay? So if you have macula-on retinal detachments, they do better than macula-off retinal detachments, regardless of the duration of macular detachment. So in Williamson's group, of the patients who detached their fovea whilst waiting to have surgery, even if it detached for 1 day, their mean visual acuity was worse than the patients who didn't detach their fovea. When should we operate then in macula-on retinal detachments? If you look at Michael Lay's group, they split their patients into 2 groups, the early group and the late group. And you can see the days there. And they found no difference in primary success rate or final visual acuity. And these are macula-on retinal detachments. But this study, they only noted in 17 out of the 66 eyes whether the macula was attached at the time of surgery. So really, it's a little bit useless information. There is no point in telling me, and they didn't even note these 17 patients, which group they belong to. So we can more or less disregard the fact that they're saying it's okay to wait 4 plus or minus 2 days, but I don't know how many people detached their maculas while I was waiting. So I found this study extremely unhelpful. So in a single surgeon consecutive series by Wyckoff et al., right, they found that if you operate on the patients within 24 hours, and 85% of patients who had surgery within 3 days, only 1 patient detached, and that patient was had surgery on day 4. So they concluded really progression, just as David said, is quite rare. It's only 0.5%. And I accept that, but progression is there, even if it's only 0.5%. And how often to the extent to the fovea? Yeah, it's nice, we're using the same references, but you can look at the references and interpret them in a different way. So in a retrospective 14-year review of St. Thomas's patients, only 10 patients were found to progress, only 1% to macula-off retinal detachment. And yes, you can predict which patients they are because they're supratemporal and they're pretty close to the fovea. But those patients only got 6/12 vision when they were operated on. So if they progress, we know that they do worse. even if they don't progress very often. Okay. And in the macula-on retinal detachment study, which was a beaver survey, 11 out of 82 cases showed progression of their retinal detachment at a rate of about 1.8 disc diameters. Okay? So we know the progression rate, and we know even rare or not rare, retinal detachments progress to macula-off, and we know that macula-off does worse than macula-on. Okay? So we agree on these, okay? But the debate is macula-off surgery more urgent than macula-on surgery? So there are times when you're always going to have to choose, okay? So you have two patients, just like David patients. You can operate on one of them in 2 days, and you can operate on the other one in 7 days. Which person are you going to operate on first? Are you really going to operate on your macula-on patient and sit and wait for your macula-off patient and leave your macula-on patient another week because you don't think they're going to progress, or 1.8 disc diameters is not going to get to your fovea? Right? I can tell you what your colleagues would do in the Beaver survey. Most of our colleagues will operate on macula-on detachments within 29 hours, macula-off detachments that are fresh within 3 days, and macula-off more than a week within 2 weeks. And most importantly, and remember this because you may need it, when asked if you were involved in a medical legal case of a doctor who left a macula-on detachment progress and then lost vision to 6/24, would you go to court and defend them? They said 60% said no. Maybe in Scotland, vitreoretinal surgeons will defend David, but certainly in England they won't. And lastly, he said, I make it a rule never to drink anything that changes color when you put water in it. But last night he was drinking ouzo. So it is clear you cannot rely on anything this man tells you. I rest my case.
Okay, so let's vote again after you heard the second opinion. So which ones of you now think that a macula-off retinal detachment is a much more urgent situation than a macula-on? Please raise your hands. So the previous result was 6, it is now 3. And which ones of you feel that it's the other way around? So a macula-on retinal detachment, it's much more urgent than the macula-off? It was 12, it's now 12 or 13, 1, 2, 3, yeah. So it was 6/12 and it's now 3/13. So I think Cyprus has got this one. We should call it a day now. Have a nice evening.